So moving on to the rapidly progressive glomerulonephritis. This is defined as the severe glomerular injury. Okay, this is severe glomerular injury which is associated with the rapid and progressive loss of renal function. So rapidly progressive glomerulonephritis is defined as the severe glomerular injury which is associated with the rapid and progressive loss of the renal function. The characteristic feature of RPGN is there is severe oliguria as well as renal failure. There is severe oliguria with renal failure. This is the classic feature of RPGN. And if you leave this RPGN untreated, there will be death of the patient within weeks to months. So this is a very serious condition. In the glomeruli, we usually see the presence of the crescents formation in the glomeruli. We are going to see in detail how the crescents are formed. So the classic representation of the RPGN is crescent formation in most of the glomeruli. That's why this RPGN is also called as the crescentic glomerulonephritis. So what are the different types of RPGN we have? This is a very important table to understand the rapidly progressive glomerulonephritis. We have something called as the type 1 followed by type 2 as well as type 3. So what happens in the type 1? In the type 1, there is anti-glomerular basement membrane antibody formation. So there is anti-glomerular basement membrane antibody formation. Sometimes it might be limited to the kidney. And these anti-glomerular basement membrane formation, anti-glomerular basement membrane antibodies, these antibodies cross-react with alpha-3 chain of the collagen 4 of the glomerular basement membrane. Alpha-3 chain of the collagen 4 of the glomerular basement membrane, and the same, because of the molecular mimicry, the same collagen is also present in the pulmonary alveolar basement membrane. So when these antibodies cross react with those pulmonary alveolar basement membrane, this leads to something called as the good posture syndrome. What is good posture syndrome? Because of this cross reaction, because of these antibodies acting in the pulmonary alveolar hemorrhages, pulmonary alveolar basement membrane, this leads to pulmonary hemorrhages as well as recurrent hemoptysis. So that is the basic of the type 1. In type 2, type 2 is basically idiopathic. We can say there are no anti-glomerular basement membrane antibodies here. So this type 2 RPGN is classically seen in the post-streptococcal glomerulonephritis moving into RPGN, or the post-lupus nephritis, you can say, or HSP. What is HSP? Henoch-Nolan purpura. We are going to have a separate discussion on that as well. We can also see following the IgA nephropathy leading to type 2 RPGN. The type 3 type of RPGN is something known as the posse-immune type, and this is generally associated with ANCA association. It can also be idiopathic. So this ANCA association is also seen in the venous granulomatosis as well as the microscopic phalangitis. So out of the total 100 patients of the RPGN, almost 20% will have the type 1 type of RPGN, 25% will have type 2, and remaining 55% will have a type 3 RPGN type. So what happens in the type 1? As I just told you, there are formation of the autoantibodies against the alpha-3 chain of the type 4 collagen of the glomerular basement membrane. So when this happens, there is proliferation of epithelial cells in the lining the Bowman capsule, and this leads to infiltration of monocytes and macrophages. And ultimately this leads to linear deposits of IgG and complement 3 in the glomerular basement membrane. So this is the basic pathophysiology of type 1 of RPGN. What do we have? We have the formation of autoantibodies against alpha-3 chain of the type 4 collagen of the glomerular basement membrane. This leads to proliferation of the epithelial cells lining the Bowman's capsule, leading to infiltration of monocytes and macrophages, and finally the linear deposits of IgG and complement 3 in the glomerular basement membrane. So what is good posture syndrome? As I just told you, how is it related to the RPGN? So when these glomerular basement membrane antibodies, they cross react with the pulmonary alveolar basement membrane. And remember, glomerular basement membrane as well as the pulmonary alveolar basement membrane, they both have the same type, that's alpha-3 chain of the collagen type 4. When these antibodies cross react, the pulmonary symptoms that patient suffers with is pulmonary hemorrhage leading to recurrent hemoptysis. Along with that, the previous kidney injury, he can also have renal failure. So classic symptom is recurrent hemoptysis with pulmonary hemorrhage, and also the patient suffers from kidney renal failure should give you a hint that the patient is suffering from RPGN. And this genetically it is associated with HLA-DR-B1, this syndrome. So type 2, as I just told you, it's because of deposition of immune complexes, and immune complex formation is seen in, as I just told you, these three PSGN, that is the post-streptococcal glomerulonephritis, where immune complexes are found, and also lupus, systemic lupus leading to kidney injury, Henoch-Nolan purpura, and as well as IgA nephropathy. So that is the type 2. Type 3 posse-immune, as I just told you, there is in the type 3 posse-immune type, there is lack of detectable antibodies. There are no anti-GBM antibodies. There are no detectable immune complexes formation. So what is this posse-immune? In the posse-immune, it's generally found that in the posse-immune in blood we can find the ANCAs. What is ANCAs? Anti-neutrophil cytoplasmic antibodies. So in the posse-immune type of RPGN, most patients of this type of RPGN have circulating anti-neutrophil cytoplasmic antibodies known as ANCAs. We have two types, that is P-ANCA and C-ANCA. Earlier they used to be called as P-ANCA, what is perinuclear ANCA, and C-ANCA, that is cytoplasmic ANCA. Nowadays P-ANCA is called as the MPO ANCA, that is myeloperoxidase ANCA, and also C-ANCA is called as PR3 ANCA, that is proteinase 3 ANCA. Okay, in RPGN, what will be the morphology of the kidney? The kidney will be generally enlarged and pale, and there will be petechial hemorrhages on the cortical surface. So the kidneys are generally enlarged and pale, and the petechial hemorrhages will be seen on the cortical surface. This is the morphology of kidney in the RPGN. On light microscope, we can see focal and segmental necrosis of the glomerulus. There will be distinct crescent formation in the glomerulus, as well as we can also see proliferation of the glomerular epithelial cells along with monocytes and macrophages. This is the appearance of the light microscope. On immunofluorescence, we can see linear GBM, IgG and C3 deposits on the glomerular basement membrane, that is the type 2. In electron microscope, we can also see a proper rupture in the glomerular basement membrane, leading to the leakage of all the proteins, blood cells and everything. So clinical features, common clinical features of the RPGN, that is rapidly progressive glomerulonephritis. It is similar to the nephritic syndrome. The patient suffers with hematuria with RBC cast in the urine. There is moderate proteinuria reaching nephrotic range, and there is also hypertension as well as edema for the patient. If the patient has autoreaction with the pulmonary, we can call it as good posture syndrome, where the patient suffers from recurrent hematopoiesis as well as the recurrent pulmonary hemorrhages. Specific lab diagnosis for the RPGN is we can also find something called as anti-glomerular basement membrane antibodies. If it is type 1, we can find anti-nuclear antibodies as well, and if this posse-immune time, we can find P-ANCA and C-ANCA in the blood. So management, we can do plasmapheresis, that is plasma exchange. We can remove all those antibodies from the plasma and give back the plasma back to the patient. We can put them on steroids. Steroids will suppress the immunity, so antibodies will be suppressed, or we can also give immunosuppressants to the patient so that antibodies are not found. When the patient goes into RPGN, there is a very few patients who recover, and most of the patients will progress, leading to further kidney damage. Finally, the patients will have to undergo chronic dialysis for the rest of their years, or the definitive will be the transplantation, where it cannot be guaranteed because those antibodies can also react with the new kidney, so it can also fail again. So this is the recovery for the patient suffering from the RPGN. So finally, ending lecture with the thought for the day. So what is the thought for today? You don't want to look back and know that you could have done better. So whatever you're doing right now, studying, everything is peaceful and everything is better. So sometimes whatever you do, you don't want to look back in the future and know that yes, I could have studied something, I could have done that day. So you don't want to regret that. So thought for the day is, you don't want to look back and know that you could have done better. So do your best every day from today. Thank you guys.